contexts like Somalia, where already services were already limited, in terms of access to care, it means also people arriving in late forms of disease because they try to hold back since the nearest healthcare facilities are not having services available, or knowing that when they go to a healthcare facility, only certain services are available and others are not available. So we see this fragmented way of service provision or cost sharing that was not there before the funding cuts. For areas where we work, for example in Somalia, normally the services that are available in those facilities are mostly just as only available services to the populations. So when they close, that means people have to resort to other coping mechanisms or ways of accessing care. That could mean people incurring heavy debts to get to healthcare facilities in far distances, or it could also mean people resort to using traditional healers. And sometimes it's complicating the medical conditions of patients. For example, we will see patients coming to the hospital, for example, a 5-year-old child that was in a hospital with an eye removed, which doctors were suspecting was cancer. And when people resort to these kind of measures within the community, that means when they get to a healthcare facility, normally the conditions have worsened, or there's little that can be done for a medical perspective to deal with the situation. With MSF as a medical humanitarian organization and mostly versed or mostly inclined to support emergency responses, we naturally by mandate do not have the capacity to support overall healthcare services in the context where we work, but also it's generally impossible for any one donor or one organization to provide healthcare services in places with immense humanitarian needs, not just from health to other issues that also correlate with healthcare.